The next speaker to round out this first session is Professor Cesar Nomura, who's a radiologist who's basically done anything that's worthwhile doing in terms of cardiac CT or cardiac MR, Sao Paulo. He's the director of his cardiovascular institute in his radiology department. He's director of the Society of Cardiovascular CT in Sao Paulo. But more importantly, Cesar is not a martial artist, but he is a drummer, and he's been in a jazz band and he plays at church. The only reason they let him in church, he plays music, and he plays every Sunday, and he strikes a rhythm. And he's going to be talking about MR, I believe, right?
I believe so.
Yeah, excellent.
So thanks a lot for the kind introduction. It's my pleasure to be here. It's my fourth time here in Toronto. And each time I come here, the city is getting more and more beautiful, but the traffic is getting worse. Not as like São Paulo, but I mean, but that's the downside of the development. So I will talk about cardiac MRI. First of all, a little bit of our institution. So all buildings that you are seeing here in the picture is part of our institution, not the stadium. So this is not part of our institution and not the cemetery here. So it's just a coincidence. So it's our department. So we have 13 MRI scanners, 1.5, 3T, on 7 Tesla that we are dealing with, and a PET MR. And we have 14 CTs. We perform around 2,500 cardiac MRI and 4,000 cardiac CT a year. So the majority of our cardiac MRI we perform in the previous Toshiba scanner, 1.5 Tesla. And those are my disclosure. We have a research agreement in collaboration to develop some techniques, the KT speeder acceleration and also the T1 mapping. So from the basic, I want to talk about the ischemic heart disease because our previous speakers already covered this, and I will talk about non-ischemic heart disease and the basic sequence for the cardiac MRI. So we have the CINI, so the steady state free pulsation sequence, the bright blood sequence. We have the tissue characterization that are the double IR or triple IR inversion, T1, T2, and the delayed enhancement sequence, so for the delayed enhancement. So basically for non-ischemic heart disease, those are the three mainly sequence that we use to evaluate cardiac disease non-ischemic. And now talking about the latest advancement, so I will talk about the acceleration technique, the 3D delayed enhancement sequence, the T1 mapping. I will try to talk a little bit about the strain, and I will not cover T2 mapping for the flow. I don't have experience with those techniques, but you can read there are a lot of papers coming, and the data for those T2 mapping and 4D flow are not that established as the other ones. So, but before starting talking about the sequence, it's important to understand that sometimes we spend a lot of time trying to find 2-chamber view, 4-chamber view, short axis, and the autolocator now that is available in all different systems is something that makes a lot of difference. We're going to show the one that we are using, that from the axial planes, so the localizers, so with just one click like this, so we are running all 6 planes, and it saves a lot of time. So and then you can do a manual adjustment. You can do some to see if really in the correct plane, and you can change for the plane that you want. And this is our data that we count the numbers of click that our technicians used to do for a regular cardiac CT. So it used to be 2,000 clicks in the mouse for one cardiac MRI. This is the median. It used to be 14 minutes. Using this new technology, so we drop to around 4 minutes at 39 clicks. Even in a beginner person or a very experienced technician. And this is mean like 83%. The median would be something 83% reduction in the time, not scanning, but the time that just preparing for to get the sequence. Now moving on to the acceleration techniques. We have here, it's not new, it's more than 15 years that it started the parallel acquisition, so the KT and many other different type of sequence. We have the BLAST, the GRAPPA, the KT, and what we saw is the acceleration factor up to 10 times. In this, I would discuss about the KT, the sequence that we have experienced. So the difference from the previous one, the traditional ones, to the new one, is the training scan. It used to be necessary a training scan. So the new KT speeder, so you don't need the training scanner. And you can, so it saves some time and you can speed up the factor up to 8 times. And to show some images, so this is the accelerator factor, so for 4 to 8. So the image quality is quite nice if you compare increasing the speed factor, and it's quite a nice image, so you don't see, when you look in detail you will see difference, of course, but I mean from some patients you can speed up and you can use the factor up to 8. So here's to compare. So this is a regular scan, this is the with KT speeder. So basically this is one breath hold for each slice, and here is just one breath hold and you acquire the entire heart. So of course the resolution is not the same, but it's quite nice. And what you can do is you can do breath hold sequence. So this is the regular one, acquisition, with 24 phases. But if you want to go for a better resolution, so you can go up to 44 phases. So and then you can see, so the contraction is more smooth, and you can look into, let's say in the future, if you want to try to see diastolic dysfunction, maybe this can help. So you can use this, or even you can do free breathing acquisition. So this is the regular one with the free breathing. Sometimes some patients cannot hold the breath, so you can run the sequence. But with the KT speeder, with all the different speeders, so you can run with a better resolution and with a good image quality and with a 44 phase with the patient breathing. You can also, so this is the whole heart. Of course, so it's 20-second breath hold and you can acquire the entire heart. It's a lot for some patient. You can split in 2. Of course, the resolution is not that high. The number of phases are low. So, but if you want, you can go for a higher spatial resolution and temporal resolution with a 1 breath hold. So it depends of what you want, what kind of pathology you are trying to see, and you can play with the acceleration technique. Just to compare, so this is the regular one. This is with a speeder. So in this one is 12 times breath hold. This is 2. The majority of the case we split in 2 or 3, and you save a lot of time. So it's 156 seconds, and here is 36 seconds. So resolution, temporal resolution are quite similar. So and of course, if you really take a look here, the image quality here is better. But I mean, it's still diagnostic. It's still diagnostic image. So and we can see the septal bouncing related to the pulmonary hypertension. We can do good measurements. So why not go to less time scan as compared to have a very nice image quality? What really we would like to avoid is this kind of images. So because those crappy images related to breath hold, so patient that could not hold the breath. And this was the validation, the clinical validation of this sequence about the use of the technique KT speeders, and we included patient healthy volunteers and patient with heart failure. And what we found was a reduction in 61% in the acquisition time. So again, here is the regular one, and down here is the accelerator. We use the factor of 4. We cannot, if we use it 8, so we could drop this more. And the numbers comparing the regular steady state free precession with the acquisition with the KT. So the ejection fraction, left diastolic volume, systolic volume, and the mass was quite similar. So showing the good accuracy of this. And the conclusion of our study is that going to the acceleration technique, so it's feasible, so very good image quality, and but what is the main point is the considerable reduction on acquisition time. That was 60%. So this is the new one that is coming. That is the same acceleration technique, but now is retrospective. And you can see here, so you can go to a speed factor of 16, and the image quality is a little bit better, and is more smooth, the contraction of the heart that you can see here. Okay, moving on to the late enhancement technique. So this is I would like to talk a little bit about the 3D delayed enhancement. As I showed before, it's very important for tissue characterization, and the validation of the 3D delayed enhancement was published a long time ago. It's not new. It's quite in pigs and in some humans, and they compare 3D with the 2D and the anatomy, and the correlation was very good. Showing that you can use the 3D delayed enhancement for quantification, and the accuracy was similar to 2D. There is another one, the validation with patients, showing that the 3D comparing to 2D sequence are with a good accuracy. So this is the 3D delayed enhancement that we use with a motion correction. We use free breathing. We use the navigator, and the median time was 2 minutes free breathing acquisition, and you can get images like this. It helps, like in this case, you can acquire you can acquire axial images. You can acquire axial images, and then from this you can reconstruct in 2-chamber, 4-chamber, or short axis. We have, like in this case, it's a 2 minutes acquisition with a resolution of 2x2. And from this one, you can reconstruct in different planes. Like, so it's almost isotropic reconstruction, acquisition, sorry, and you can study the short axis and the 4-chamber if you want. This is the regular 2D acquisition, late enhancement in a patient with a huge myocardial infarction here, where you can see the late enhancement, and you can see like a thrombus here in the areas of microvascular obstruction here also, so you can see. And that is the 2D acquisition. This is the 3D acquisition with a breath hold. So the previous one was free breathing, and this one is a breath hold. So you can see also a very good image quality. So it's 24-second breath hold. If you reduce, reduce your spatial resolution, you can reduce this time. But so far, the image is very good. And you can do this for 2-chamber view and 4-chamber view if you want. What we are doing, we continue using 2D late enhancement, and but we run at least the short axis. We didn't switch, we didn't change just for the 3D. We're still using the 2D, but sometimes the 3D can help when in the short axis, because we would like to see the continue of the lead enhancement, and sometimes we're in doubt about if it is gray, if it's really a lead enhancement or not. So this is what we are doing. We include the 3D sequence in our acquisitions. One thing that it would help is in the mapping. So I think the 3D lead enhancement would help in the electrophysiology fibrosis mapping. So it's important to be 2D to understand where is the fibrosis, and so it can help for you the positioning of the leads. Also, when you want to install a pacemaker, and for this, in this case, like for electrophysiology study, so they can find where is the area of fibrosis, and for the electrophysiology study. So moving to the T1 mapping, so is the next sequence that is very important because of the tissue characterization. What we know in cardiac MRI, so we have two patterns. So we have a ischemic heart disease and non-ischemic heart disease, just to simplify. So in gadolinium it's an extracellular contrast, but once you have some membrane injury, so if like in myocardial infarction, sometimes in myocarditis, so the gadolinium gets inside, and then you have the lead enhancement. Also, you can see some lead enhancement when we have a scar in the myocardium. But once you see the fibrosis, when you see the lead enhancement, that's okay. So I'm saying this is a non-ischemic or it's ischemic, and I can quantify. But there is a gray zone that is from normal to lead enhancement. Is this the diffuse fibrosis that is in the interstitial thing? And this is where I think where T1 mapping can help. So T1 mapping is characterization of the myocardial interstitium. And it's important because there are some diseases that you will not see lead enhancement typically, like in hypertension, diabetes, valvular disease, related to the age. So there is a continuum of the disease of the myocardium. The disease is the myocardial interstitium. So, and you can also evaluate infiltrative fibrosis like amyloidosis and Fabry disease, or in case of infarction and myocarditis. Like in this case, the T1 mapping. So it's a patient with a 57 years old with heart failure, ejection fraction of 37, no late gadolinium enhancement. So there is no scar that we can see by our eyes. But when you run the T1 mapping, so the value is more than 1,000. The normal number for our machine is below 1,000, is 970 something. So and this is, so for sure, this is not normal. This is the native T1. So, and we know from this that the presence of high level of interstitial fibrosis or high level of T1 mapping in some disease are associated with bad prognosis. And we can add to the T1 mapping the extracellular volume. So we use the blood sample, and we can evaluate also the extracellular matrix, that is the extracellular space volume. It's not only the myocardium. The sequence that we have available to evaluate the T1, we have a different sequence: Molly, Schmolly, Sasha, Sapphire. In the past we used Sasha, now we are using Molly, and this is the most validated sequence, is the one that we are using, is the Molly. So this is the protocol for the Molly sequence. So it's a long sequence so far. It's 17 majority, sometimes you can go lower than this, but it's 17 heartbeats, total of 11 images. And just to quickly to make some examples, the importance of the T1 mapping, like in myocarditis, you will get like native T1, elevated native T1, and extracellular volume also will increase. Amyloidosis also, you're going to increase the T1 and the ACV. Iron, is very interesting is you drop your native T1 because of the iron for sure. And the Fabry disease also you can drop. The other one disease, so you will increase your native T1. I recommend this if you want to study a little bit about how to use this mapping T1, T2, T2 star and the ECV. And what we can see, once we see like a patient like this with heart failure, with a moderate dysfunction, so no doubts of dysfunction, and we can see the late enhancement, like these bright areas surrounding. So there is a huge area of late enhancement. So we know the prognosis for this patient is very bad. So you don't really need the T1 for this patient. But like in this one, where we have another dilated cardiomyopathy and no late gadolinium enhancement, so the T1 can help. And here, like in this case, it's elevated. And we know from many papers that the T1 is another marker and it predicts worse outcomes. So mortality in those patients with high native T1 are significant higher as compared to normal T1 value when we will have no late gadolinium enhancement. Amyloidosis is another pathology that is T1 mapping is also helping to make some diagnosis, but mainly if you have like a renal failure that you cannot use the contrast, so the T1 native T1 mapping also can help. And of course, what you will have, you will increase your native T1 and also your ACV. Just to show for those who are not familiar with amyloidosis, the typical enhancement of amyloidosis is this diffuse subendocardial enhancement in the atrium and the ventricles. Fabry disease, the reason why there is a decrease in native T1 is because there is intracellular deposition of lipids. Another disease that is hypertrophic cardiomyopathy, when you see fibrosis, that's fine. Like in this case, you can see like a huge hypertrophic cardiomyopathy and you see a lot of fibrosis. So in these cases, we know that the prognosis is very poor and that T1 mapping are not going to help. But I mean, in some case that you will not see a lot of fibrosis or a mild amount of fibrosis, so the T1 mapping can help to define the prognosis of those patients. Hemochromatosis is another pathology that you can, the T2 start sequence is the gold standard to evaluate hemochromatosis. And when you have below 20 milliseconds, we know that there is iron deposition in our heart. And when you are below 10 milliseconds, we know that this person we're going to go for a heart failure, and this is a worse prognosis. But the T1 value now is very typical in the T1 mapping once you have a deposition of iron in your heart. Myocarditis, when you see late enhancement is one thing, but sometimes you will not see in myocarditis, and sometimes T2 mapping would help here, but we're not discussing T2. But T1, native T1 and T1 post-GAD also can help in myocarditis. Just the last case that I would like to bring here is the LV non-compaction. So I think you guys know about. So it's the LV non-compaction is basically all the muscle here. You have this non-compaction of the myocardium, and the relation for the diagnosis is when the area of non-compaction is over 2.2, 2.4, as compared to the compaction area. And this is the study from our group that we published showing that even in some structural disease, the T1 mapping in those patients with LV non-compaction, we show that there is extracellular volume, there is expansion of extracellular volume. It means probably there is a diffuse fibrosis. So there is interstitial fibrosis also related to LV non-compaction. It's not just structural, but there are more than that in those patients. And to finish, myocardial strain, I'm almost in my time. So it's deformation. So it's similar to echocardiogram, to ultrasound, that you can evaluate the myocardial, the contraction of what is going on with the muscle. And just to give an idea, so you can evaluate left ventricle, right ventricle, and sometimes the atrium. In the future of this there is a huge horizon for this technique that you use it basically the regular steady state free precession cine, and from those data you can see if there is some initial pathology or something, what is going on with the contraction of your muscle. And how you're going to see is the global longitudinal strain. So once you get lower, it's worse. Once you get higher, so it's better. I want to get into detail, but there are a lot of disease now, a lot of pathology that you can evaluate with myocardial strain, like cardiotoxicity. In cardio-oncology, patient with cardiotoxicity, this is a new feature. Ischemic heart disease, valvular heart disease, cardiomyopathy, and many others that you can study with myocardial strain. And just to finish, so and maybe we are doing some studies with cardio-oncology to see cardiotoxicity related, and maybe the strain for those will be an early marker before the T1 mapping and before you see scar in the myocardial. So myocardial strain, there is a new features, it's the new kid on the block, and basically you don't need a new acquisition. It's basically you evaluate what you already done. So in summary, we use it, I show our clinical experience, the importance to use the autolocator because you can save some times. I know that here probably in Canada, you guys have a very good technicians, so they can run, but autolocator can help a lot to save some times. And also the importance to use the acceleration technique to reduce your scan time. T1 mapping, now we do T1 mapping, native T1 mapping for all of our patients. So we are doing for all patients the native T1. And the 3D late enhancement, we didn't switch. We're still using 2D, but we are acquiring at least in a short axis the 3D late sequence. We just started doing run some scanner of the heart. This is an explant. So it's a 200 microns of the heart in a 7 Tesla. So you can see the coronary arteries, you can see the valve, you can see the papillaries, differentiate the myocardial from the fat. So new things should be coming with I don't think this would be for clinical use, but for research, maybe it can help with the 7 Tesla. And with this, I would like to say thank you to my colleagues and thank you for your attention.